sometimes it's challenging to take a clinical practice guideline and apply it to your own practice environment.
What do you do with guidelines? Well, my first response is they're not guidelines. It doesn't say thou shalt do this.
Welcome to the Hat Rack. It's good to see you again. Of course, it's Bill McCauley here, the Associate Dean of Continuing Professional Development at the Schulich School of Medicine and Dentistry in London, Ontario. And I'm joined by Leslie McAdam, our Program Administrator. How are you?
I'm good. Good. It's a good day. We're updating the media suite a little bit, so it looks a little different.
We have had comments about the green screen.
Yeah.
So our technical specialist, Patrick Barfoot, is helping us with the green screen, and hopefully we'll be able to do something with that. So are you ready to record this episode?
Yes, it's exciting.
It's a sad day here.
You're sad?
I'm sad. It's a sad day, and it's a sad day because this is my last day of recording a Hat Rack episode with Leslie McAdam.
Yes.
Because you're leaving us.
Yes, that's...
How can you possibly be leaving us? I mean, look at the excitement, the fame, all the royalties you're getting from this. Where are you going?
Well, I'm taking a career break. So after 20 years at Western, I'm going to go traveling with my family. My 3 boys and my husband, we're jumping on our sailboat, and we're going to go sailing for about 2 years.
It's a big trip.
Yeah.
It's a big trip. It's a big sailboat.
Yeah, it's
How big
decent.
is your sailboat? Can you ask that? Can you ask that question?
Yeah,
How big is your sailboat?
Yeah, sure.
How big is your sailboat?
50 foot.
So it's a 50-foot sailboat,
Yeah.
right? And it's in Sarnia now.
Yes.
And you're going to take it all the way through the Great Lakes, St. Lawrence River, and down to the Caribbean.
Yes, and if things go well, maybe across the Atlantic towards Scotland.
Well, we are very sad to lose you, but we are excited for you because that takes a bit of courage to do that. Pull your kids out of school and take them away for 2 or 3 years. Good for you. And do you know where you're going to be when you're in the middle of the ocean?
Well, I have a feeling you're going to give me a hint.
I'm going to tell you.
Okay.
You're going to be in the rural part of the ocean, like when you can't see anywhere and there'll be no one around you. You're going to be in the rural ocean.
Okay.
And that's a great segue for today's episode, because today we're going to talk about continuing medical education for physicians working in a rural practice. Because it might be a little bit different.
For sure. And we have 2 guests this time.
We have 2 guests and 2 hosts.
Yep.
So our 2 guests, our first guest is Dr. Matt Breton, and Matt is a family doctor in Wawa, practices family and emergency medicine in Wawa, Ontario. There's more than one Wawa, I found out. There's actually a Wawa in the United States, too. Did you know that, Matt?
I know there's a series, a chain of department stores called Wawa. I didn't know there was a town in America.
So you practiced there since January of this year. Is that right? And prior to that, though, you were doing some locum work in other rural places. Am I right?
Yeah, I actually did my... I trained at University of Toronto, and in the family medicine residency, you have a 2-month rural block called teaching practice. So I actually did my 2 months here, lived in the hospital basement during that time, managed to fall in love with it. Then I was a recurring locum here as well as other places in Ontario and Northwest Territories for 2022 and 2023, and then have settled here as of January.
Great. Well, we're excited to have you here, especially as a freshly minted and early into practice physician. Our other guest is not freshly minted, but always fresh. It's Dr. Ken Milne. Ken is an emergency physician who has worked in rural Ontario for upwards of 30 years. And Ken also is pretty well known, I think, in the emergency medicine community for running the Skeptic's Guide to Emergency Medicine, has his own podcast. So welcome, Ken.
Well, after hearing that wonderful intro, I think I should say ahoy, Leslie.
Oh, yes. Thank you. Welcome
That
to
sounds
the Hat
so
Rack.
exciting. 2 years on a sailboat. I hope we're talking about that today.
Yeah, well, we'll probably touch on that from time to time. But I'm sure there'll be times when it's exciting and times where you wish you were on land when you've got 3 young boys on the boat with you.
Yes, for sure.
Okay, so we wanted to talk about CME for rurally based physicians because certainly keeping up to date, keeping current in your practice is always a challenge. But it's a little bit more challenge if you're relatively collegially isolated. You know, we've talked about this a little bit. In a former life, I worked for the CPSO, and we identified that collegial isolation not being in regular contact with a lot of colleagues is a big risk factor for falling out of date. Whether you're practicing in a rural practice or even in downtown Toronto, if you don't have any interactions with colleagues, you can quite easily come out of practice. Matt, you are relatively new into this. Why don't you tell us a little bit about your practice? Tell us what things are like for you in Wawa. I know you've been there sort of just since January full time, but you've been there on and off since 2021, 2022. What's your practice like?
Yeah, so I have a practice of about 700 patients right now. We're trying to build that up to 850 at least. And then the way our hospital is arranged is that we share ER call responsibilities. So every couple of days, we do a 24-hour emerge call. Any patients who are admitted to us, or any patients that we admit who are our patients become our inpatients, or any orphaned or unrostered patients who need admission, the emerge doc who admits them that day continues the care for them.
Great. So you're relatively new to your practice. It's just been a couple of years. Have you found any particular challenges in thinking about continuing education?
Yes. I would say the biggest factor is time. Free time to continue to read around cases, to attend conferences or extra training opportunities. We've managed to kind of bake that into our schedules as a group, and we've had some continuing medical education arranged the Center for Effective Practice, which has been very helpful. But I would say that in terms of just budgeting the time for it, it's quite difficult when you're, doing a 24-hour emerge shift, or you're up all night and post call the next day. What free time looks like on your calendar might just be time spent resting and rejuvenating. Yeah.
So time has been the biggest factor since transitioning from residency to practice.
Yeah, like in terms of access, so much is online now. In terms of even like CAPE was holding conferences online during the pandemic.
Dr. Milne, with 30 years experience, can you highlight a few challenges you've experienced then and now?
Sure. And Matt, time is a finite resource, and it's the crucible in which we all burn. And so finding the time, it's very challenging at all stages of your career. So I hear you, and I hear what you're saying. And certainly over the 30 years, it has changed for me, because when I came out, it was just waiting by the mailbox. When is that, next journal article going to arrive? And they would just, I don't know, Bill, would they stack up on your bedside table, just getting larger and larger and larger, going, I'm feeling worse looking at that every night, going to sleep, going, I should be reading this, but I'm just so tired, Matt. I need rest. But it's really changed, right? I started subscribing to some programs that would come as a CD. That's a compact disc, Matt. That was a joke, by the way. But I usually have to explain what a record player is to my kids. No, I know, but I have to explain a record player to my kids. So I bought one for the holidays one year, just so they understood what a long playing album was. But yeah, I know. And then it went online, and you're absolutely right, Matt. It goes online, and now the way we can consume it can be more of a pull, right? With social media and podcasts, we can pull the information and sort of target and go, I think, this is adult education. I have a deficit here. I saw a case around this. What's out there that I could pull from the World Wide Web and bring that information to no matter where I am? And then time leverage it to get it back to what you said, Matt. And so maybe I can do this on my way to a house call in a rural area that's going to be a 20 or 30-minute drive. Well, I could listen to a podcast about congestive heart failure, or I need some exercise because I need to stay physically healthy to be able to practice medicine. And so maybe for that half hour to an hour of exercise that I can squeeze in, again, I can listen to a podcast or watch a video if I'm doing it in an environment that I can do that with. So that's how it's changed with the technology, to be able to pull that information and deliver that upstairs.
One of the things that we've talked about on this podcast in the past is the importance of learning from your colleagues. And, as a practicing emergency physician, I know a lot of the things that have caused me to change my practice have come from observing or interacting with my colleagues, seeing what they're doing, talking to them about cases, that sort of thing. The availability of that might be a little bit less in a rural environment, especially if you're covering an emergency department 24 hours and you're solo, and maybe you're the only doc in town because everyone is away. And so are there challenges in that regard, working in a rural practice and being able to learn from your colleagues, or is it that you rely on those things a little bit less? I want to hear from both of you because things will have changed over time for Ken. Matt, what's been your experience?
I think part of the excitement of doing the locum circuit, it's really good for your development, especially fresh out of residency, where you're kind of competent in all the fields. Nothing's really rusty yet. Going to centers with limited resources, talking to physicians who've been training at other places for different amounts of time. I found it was a really good way to kind of consolidate my practice as I got out into my own career. Currently in Wawa, I'm one of 3 doctors, but the other 2 doctors have been practicing in the community for 25 years. They've both got kind of specialized focuses that they also do in the hospital. I find that talking to them has been very helpful, and we have such a small, tight-knit practice amongst ourselves that is very collegial, that I'll just walk into their room and be like, hey, come look at this. Or if I'm on call and one of their doctors has an OB practice and there's a pregnant patient, they're always happy to talk to me and run it through. One of the other benefits we have is because we're in such a small environment, you get to know the specialists really well. And I find that I'm talking to the same orthodox, cardiologists over and over again. So you build a relationship with them, and again, in a lower volume emerge, you do have a bit of luxury of time. So a lot of that phone call is spent talking about the case, considering your differential, and this is what we should do in terms of next steps, in terms of management. So I find that you're learning on the job a lot in rural medicine because you're the only person there sometimes.
What about interprofessional learning? I've worked a little bit in some rural places from time to time and find that the nurses have been a fantastic resource for what's available in that community and for helping me to understand the way it's done there. Have you experienced that as well?
Yes, especially in terms of like allied health. We currently don't have an occupational therapist. We currently don't have a social worker. That being said, the reception and admin staff at our clinic are like the best I've ever worked with, and they quarterback a lot of those social supports that people might need, and we have ways of brainstorming how to get around our limitations. We have a nurse who's kind of has taken on a geriatric memory clinic sort of role after the previous physician who did that left. Even the X-ray technologists here are super helpful. When I'm doing a POCUS and I'm not sure what I'm looking at, they'll come over and look at it, tell me I'm doing something wrong. I adjust it and correct it. So I feel like in such a small place, people, again, the same way that I'm a family doctor practicing emergency medicine and inpatient care, people take on a larger role than they otherwise would, simply because there's less people. So your value in a team becomes greater. So everyone kind of develops their own niche or special skills that you can draw from.
What about you, Ken? What have you learned over the last 30 years in terms of what's your experience, I would say, in learning from colleagues in a rural practice where often you're the only doc around?
Yeah, it can be a challenge, especially when I first started out. So isolating at times. You're doing a 24-hour shift. There's not many people, not many other physicians. around, and you're the only one on for 24 hours because everybody else has been working the 24 hours before or 24 hours after, or they have other responsibilities in the OR or doing OB or covering the nursing home. I mean, this is womb to tomb, cradle to grave care. But Matt, something that you said really piqued my interest about, that you're learning something and reaching out and speaking to the nurses, the diagnostic imaging people, maybe that's the lab. Everybody is very, very supportive in a rural environment, I find. And I don't want you to lose that. I still do that every day. I'm learning something new and from a whole variety of people. The only thing that's different now, I think, is I don't feel so isolated because, well, it may be in the middle of the night. It'll be the middle of the day in Australia. And I've got a friend over there, Dr. Casey Parker, who's another rural doc, and he'll be up. It's his midday or something like that. And I can reach out to him and say, hey, have you ever used this medication for this indication? And he'll be like, oh, hey, Ken, how are you doing? It shrunk the world. And I really am an advocate for social media because you can find your people, your rural people, and we're facing the same rural challenges. And so I really like the fact that you can have those conversations with other experts, whether they be in emergency medicine or rural medicine or any other specialty, and seek the wisdom from the crowd through social media.
Yeah, I'm interested in some future strategies you have right now. What are your plans for like maybe the next year or the next few months for CME?
Just as a tangent, I often reflected during my medical school experience. I'm like, how did people do this before the internet? I couldn't have even imagined, having a clinical question, going to the library, reading an index. I feel like
reading an index, we had to use microfiche.
Yeah. My education has largely been crowdsourced, and I feel like I stand on the shoulder of giants in that regard in terms of how much information is available at your fingertips to really, learn and, doing a local nerve block for the first time, or learning POCUS from scratch,
Yeah, I hear you, and I think the difference is the skill set isn't how to find the information, because the information is so readily available. The opposite is true. It can be like drinking from a fire hose. It's just overwhelming. And Leslie, when you say what's the future strategy, is how do we rein this in a bit, because it's like I said, it can be overwhelming. And I think the next steps in medical education and staying up to date and continuing professional development is to have the critical appraisal skills, to have those strategies to find the signal out of all the noise, because there can be a lot of noise out there. And how do you find the high quality stuff? Like you said, Matt, I want to do this nerve block using POCUS. Where do I go to find that information? Because there's lots out there on it, but is it good?
Yeah, and as a tangent to that, we recently recorded an episode on the use of AI in medical education, and having some critical appraisal skills to have the understanding of what information you're getting through AI is applicable to your own practice is going to be very important for the future, because there's going to be all sorts of tools coming out to help physicians diagnostically, help you with your administrative tools as well. And even just the use of generative AI, you have to know how to apply and interpret what is coming out of that information, just like you have to know how to apply and interpret what's coming out of a journal.
And that's a really good point there, Bill, because these are just tools, and we've had various tools come through the past. Matt's probably come through the whole. We can ultrasound so many different things, and the technology is shrunk down into a handheld unit that we can reach in. But imagine when that was the stethoscope, and then we got laboratory tests, and then we've got like X-rays, and then it became MRI. How do we interpret that information, and how do we use that tool? And I think that's the next challenge. Like Leslie was forward-looking. Where's the future going in this? And I'm very interested in using large language model and things like ChatGPT to create something that you can trust. And I've been looking at using my Skeptic's Guide, my 12 years of critical appraisal, and say, can I just search that? so that I can trust that information and I can use a large language model to produce something that's in that skeptical voice so that they can search it and have access to it, but in a natural language format. So that's where my headspace at, Leslie. That's where I think the future, at least for me, is going.
One of the things that I've heard from a colleague that works in a rural environment is sometimes it's challenging to take a clinical practice guideline and apply it to your own practice environment. So especially if you're working in a rural-based community with potentially limited resources. Have either of you experienced that, some challenges in implementing a clinical practice guideline so you know what you're supposed to do, what you're told you're supposed to do based on the CPG, but you can't implement it where you're practicing? Matt?
Yeah. We've only done one so far since I've been here, so
okay.
My experience may be limited. So we did one for COPD management, primary care. I found the best part of the CEP was, the resources to which they link, and there were opportunities to do like online pulmonary rehab or even local pulmonary rehab referrals that I was otherwise unaware of. Even things like a strong lungs, weak hands continuum. So, for people with okay FEV1s, but really bad arthritis, what is a puffer that's actually easier for them to use, or someone who's got weak lungs, weak hands, what would be the best puffer for them to be able to self-administrate. In terms of like implementing the guideline, I mean, I guess one suggestion that is difficult to do here was, they said any change in health really should be considering repeat spirometry, even if it's like an unrelated to their respiratory status. Say they're admitted to hospital for cellulitis, you may consider wanting to do repeat spirometry. I just find in terms of accessing that, it's a bit harder here. We do have local spirometry here, but we don't have access to the full pulmonary function test. That's about a 2.5 hour drive one way for the patient to do. So to ask them to do that, anytime they get cellulitis is a bit unfeasible and places like an unfair onus to the patient. So that's when Gestalt comes in and thinking like, how likely is this to actually give me meaningful information that I'm gonna change the way I'm managing this patient? That's something I always ask myself. Do I need this test right now at 11 p.m.? Do I need to call in the lab? We only have one lab tech who's qualified. Like we only have one certified lab tech who can run the machines. So they're on call 24 hours a day until they get a locum. So do I need this test now? Or can I, kind of manage empirically till they come in their scheduled time in the morning so that they don't hate their life and hate me and are tired and aren't able to do the work for the rest of the day. So there's a lot of managing and quarterbacking a limited team and limited resources that you've got to consider at all times.
You have just beautifully described the philosophy of evidence-based medicine. I love it. It was a beautiful explanation because there are 3 pillars in evidence-based medicine. And, Bill started with, what do you do with guidelines? Well, my first response is they're not guidelines. It doesn't say thou shalt do this or thou shalt not do that. So the 3 pillars of evidence-based medicine, Matt, that you just went through was, okay, what's the guideline say? What's the literature say or suggest I should do? But then I've got to think about my clinical situation, my clinical context, and use my good clinical judgment. And then I've got to ask the patient about their values and preferences. And that's the 3rd pillar. So, if you've got, like you use your example about the cellulitis, is it really feasible and appropriate to ask and expect that patient to take a 2.5 hour drive each way and in winter Canadian weather at times? And will that change my clinical interpretation of this situation? And how does go back to the primary literature that informed the guidelines? Did they take that into consideration? Probably not. And so just a beautiful explanation there of evidence-based medicine and how in rural practices, we've really got to think about that because you can't just use the evidence. You've still got to use your clinical judgment. And patients may be a bit different in rural areas and in different expectations and preferences.
Yeah. Another example I can think of is when I first got here, or when I was first locuming here, anyone who I thought had, venous insufficiency, or, someone was having orthostatic kind of syncope, pre-syncope, and you kind of narrow it down to venous insufficiency. And they've got okay pulses, they're an older person, because one of the guidelines for compression sock therapy is that you should rule out peripheral arterial disease. So when I was, fresh out of practice or fresh out of residency, I was, ordering arterial Dopplers for everybody just to rule out peripheral arterial disease, which again is that 2.5 hour one-way trip. Wait all day for the ultrasound, 2.5 hour drive home. You're really budgeting a day, if not a weekend, for some people. And a lot of the people that I'm considering this in are, in an advanced state of age. They may not drive. They may not have family members who are able to transport them. So my practice has kind of changed around that, where now I'm like, okay, let's try compression socks. But if you're getting, I just counsel them on the symptoms. If your limbs getting painful, numb, tingly, cold, take it off. Come back in. And the benefit of being in this small town is that people really do have buy-in, and they're able to access the emerge very quickly if needed. So people really are good at adhering to your recommendations and your treatment plans most of the time.
So it's evidence-based with a huge sprinkling of common sense.
Yes. It's human-based.
Human-based. Love it.
Well, we're called the Hat Rack, and we would like you to leave something for people to hang their hat on. So we're wondering if you have some tips for the future or from the past that you've learned that you'd like to share with the listeners.
So tips on how a rural-based physician might approach their CME or their CPD, given the constraints that come along with being relatively isolated.
I don't know. It's hard for me to reflect on it because I'm so fresh out of practice. I mean, I know I want to go to a few conferences. I know I want to do, the EDDI 1 and 2 courses. And, one doctor here does colonoscopies and endoscopy. The other one does stress tests. So try to find, maybe a niche that I can contribute to in the hospital would be a goal of mine.
Get some specific training in a certain area where there's a need.
Yeah, exactly. Finding a documented need and kind of filling that in. And as Ken said, to kind of appraise the information, not only from an evidence-based perspective, but from that common sense perspective. One website podcast I found, First 10 EM, which is found a few articles by Justin Morgenstern, who practices out of Toronto, and he's got many papers where many articles where he'll take a paper in RCT and he'll kind of dissect the methods, the results, how the results were measured, and really from a critical appraisal perspective, which I've actually found inspiring, and I want to apply that frame of thinking to when I'm reading a paper.
Justin's a great guy, and he's got a great website, that First 10 EM, and he really encourages people how to think, not what to think. He gives his interpretation, but it's also a nice way to say, how should I approach the literature? How should I read an article? That was a good point. Leslie, I was thinking about this while Matt was speaking, and so my 3 things would be, I would encourage people to find some podcasts because I'm a podcaster, so that's my bias. So I would say find a podcast that you enjoy and then can consume when you can, and be skeptical of the content that you're hearing. And then the second thing I would encourage people to do is to engage in social media. And I know that can be toxic, but we are social media. We are the people in social media. So reach out and connect with some of the people in med ed, right, in medical education, and reach out with curiosity, lots of questions, not too much judgment, and try to really be kind online when you're engaging, because tone can be difficult on social media. And then the third and final sort of thing that you can put your hat on would be to still go and meet people in real life. go to conferences, go to meetings, meet those people that you've heard on podcasts, meet those people that you've been engaging with on social media, and then bring that back to your own rural environment, because those conversations that you have in the hallway at conferences can just sometimes be better than the PowerPoint presentation that you just sat through. You can get some really good information from that, and then meet those people that you've been following or listening to on podcasts and engaging with on social media. So those would be my 3 recommendations.
Great. Well, listen, thank you very much. This has been a fascinating discussion. We haven't really ventured into this area, and it's great to get perspective on people at, I don't want to say opposite ends of the spectrum, because that would suggest that Ken is nearing the end of the spectrum, and I don't think he is. So, but someone fresh into practice and someone with lots of experience, we really appreciate your input. And, the other thing is, Leslie, finding docs who work in a rural practice, docs who work in a rural practice are busy. They're not like those of us in the city that have got lots of residents running and medical students running around doing the work for us. They're the ones that do all the work, and so they're busy docs. And so thank you very much for giving us a little bit of your time.
Yes, and a shout out to all rural medicine as well. Thank you. We appreciate it. I grew up in a rural town. My mom worked 38 years as a nurse with the same family doctor. He worked before my mom started. He worked after my mom started. So, Ken, you got a lot of years to catch up to him. Yeah. Okay.
Thanks very much, guys. Well, what'd you think of that?
I think that was a great topic that we were talking about. I almost feel like I heard like the Visa commercial on there where they used to say things are priceless, right? Like go to the conference, costs so much, go and, pay your registration fee, all the food you have to pay for, but talking to the people while you're at the conference, priceless.
Okay. So you learned that. You know what I really liked? I liked the conversation about the clinical practice guidelines and the conversation about them not being guidelines, but guidelines. And you have to, it's not what's in the guideline, it's how you interpret and apply the guideline in your own environment. And that's going to be very different based on where you live.
Yes, you need to know the guideline, right? And then you have to figure out how it's going to work within your community, and that's where
sometimes it's just not going to work where you live, right? Okay, that makes sense. And then I also, I'm not a big fan of social media in general, but I agree with Dr. Milne that social media for docs gives you lots of opportunity. I think he's basically suggesting that we all become TikTok docs.
Oh, well.
How'd you like that?
Well, I know he's definitely encouraging platforms that are like med ed focused.
Yes.
Right? Not general public.
Not
focus.
General public. Okay. Well, and with that, I think we will sail off into the sunset on this episode, and we will wish you well. And we know that you'll be listening to every episode while you're in the middle of the Atlantic Ocean.
That's right. Through the Starlink. Yep.
In rural Atlantic.
Yes. Thank you.
All right. Take care.
Thanks.
You've been listening to The Hat Rack, hosted by Dr. Bill McCulley and Leslie McAdam from Continuing Professional Development at the Schulich School of Medicine and Dentistry at Western University in London, Ontario, Canada. Technical assistance for The Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Beresnick. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack, that's all one word, THEHATRACK @uwo.ca. Additional episode information can be found online at www.schulich.uwo.ca/CPD. For The Hat Rack, I'm Stephanie Giberson-Kirby, Faculty Development Specialist at the Schulich School of Medicine and Dentistry, leaving you with something to hang your hat on.